Today we're going to be doing a cardiac assessment on a 27-year-old female. I put together a little case study for us. A female was found down in her apartment by her mom. Initial GCS was 344. Mom called 911 and reported some concerns of IV drug use to the paramedics. Patient did receive Narcan ×2 en route. She was awake on arrival. She denies any drug use, but she did improve on Narcan administration. She reports having the flu for 2 days and says that she remembers fainting while she was going to get a drink. So our general assessment, she is conscious, alert, and oriented. Pupils are equal, 4 millimeters, sluggish. Lung sounds are diminished over bilateral bases, and we've got some crackles in that right vesicular field where she had been laying on that side. Skin is flushed and hot right now. We have a recent history of a percutaneous fixation of the 5th metatarsal. That was about 6 weeks ago, and no chronic history. She takes a tricyclic birth control, nothing else, and she does have a distant history of having her tonsils removed when she was 10. Mom says that was because of recurrent strep infections. So initial vitals were 98 over 52. Heart rate was 125 after the Narcan, respiratory rate of 22. She was satting 89%, and so they applied 15 liters non-rebreather to get her respiratory rate up a little bit, or get her respiratory rate down a little bit, get her sats up a little bit. Her initial temperature was 103.3. Her vitals now are 106 over 54. We have a heart rate of 112, a sinus arrhythmia on the monitor, is tachy with some PACs. Respiratory rate is 14 at the SAT of 98 on that 15 liters. She is unlabored. Our temperature is 102.1 after we've started the IV Tylenol. We've gone ahead and drawn a CBC and a CMP to get an idea of what her blood counts and electrolytes are, how her kidneys are doing. We are also going to do a SED rate and a C-reactive protein, get an idea about her inflammation. Going to do some troponins, do a cardiac workup, get a D-dimer. We do have some concerns for pulmonary embolism due to that tachycardia, and we have some inverted T waves on the monitor and some reduced oxygen saturation. We've started our sterile blood cultures. We've got 1, we're going to do 3, and now we're going to begin our cardiac assessment. So we're going to start with our peripheral perfusion. I'm going to check here for radial pulses. I've got an equal +1. Rate is rapid but regular. We've got a little bit of a collapsing pulse. I'm going to move down here to my distal pulses in my feet, and they are palpable, lightly palpable. I'm checking for dependent edema. We've got trace non-pitting edema in both ankles. So now we're going to take a listen to her heart. We'll see how these valves are doing. So we're going to start up here at the sternal border on the 2nd intercostal space, so 2 spaces down. And we're listening for a murmur in the aortic region. We've got an S1 and S2. No S3 or S4. No murmur that I'm hearing. So we're going to move across the sternum. Stay on that sternal border, 2nd intercostal on the left side. Now we're listening to the pulmonic region. S1, S2. Sounds okay. And we're going to stay on the sternal border, and we're going to move down to the 4th intercostal space, tricuspid area. Here I'm starting to hear a pansystolic murmur. It's not particularly loud yet, but I hear some noise between S1 and S2. Now we're going to move to our 5th intercostal, to our apex, listening to the mitral valve, and there it is. There's our pansystolic murmur, drowning out our S1 and S2. Get a loud 4 out of 6 quality. We'll see if it is. Could you lift your arm for me? Radiating out here to the axilla, and it is. And that is our trouble with our mitral valve. So we're going to have you lay down now. Put your feet up. I'm going to listen to your neck with my stethoscope. I'm going to listen to the carotid arteries to see if there's any stenosis. Not likely in a 27-year-old female, but it could be an indicator of peripheral vascular disease. Could complicate our case here. I'm going to avoid the cardiac sinus. I don't want this girl to pass out on me again, so I'm going to start and move down to the medial, and then just proximal to the heart. And then come over to the other side. And I'm not hearing any narrowing, any fluid that would indicate stenosis. So now I'm going to have you just lay with your hands to your sides. I want to see the jugular veins. So I want to see if we have any issue with blood returning to the heart. I'm going to have you turn your head this way. And as I do that, I'm going to look for the pulsation of the internal jugular. If I are the internal, if I'm press on the belly right here, I'll get that jugular reflex. And now I can see the external palpate, or that external pulse there. And I don't have any distension. But if I did have any distension, I would measure that distension at a 90-degree angle, coming off the chest here. I would just need a small ruler, which I have fabricated. I would just need a small ruler here to see what the extent of that distension was. So you can go ahead and sit back up now. We have some concerning findings for infective endocarditis. We probably do not have any mitral valve prolapse. I did not hear the diastolic click that would indicate to me that that mitral valve had stiffened, though we do have a history of streptococcal infection. So we're going to get her over to echo. We're going to be NPO status at this point. We're going to get her over to echo. We're going to anticipate some empiric antibiotics until we get those blood cultures back. We do have some concern with the IV drug use and also with the recent surgery. And we're probably going to anticipate a PET scan after that if it turns out that we do have infective endocarditis, so that we can visualize those septic thrombus and anything septic in the myocardial wall. That's good.